The following podcast is part of a certified educational activity. Access the entire activity and complete the post test at peerview.com/PGX860. Downloadable slides and practice aids are also available.
Greetings and welcome to Collaborative Strategies for Managing VOD SOS, Interprofessional Insights on Diagnosis, Severity Grading, and Treatment. I am Dr. Ken Cook from the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. Joining me today are two of my colleagues. One is my pharmacy colleague, Dr. Blair Nofer, and the other is my nurse practitioner colleague, Megan Burris. Blair and Megan, can you say hello, please?
Hi, Ken. Thank you for inviting me to join this talk today.
And thank you also for letting me be a part of this discussion. I'm very excited to discuss VOD.
As am I. Today, we're going to explore a team-based management approach to one of the most serious post-transplant complications, veno-occlusive disease, also known as sinusoidal obstruction syndrome. Now, during the program, I'm going to periodically share several resources for VOD diagnosis and management, so you might want to refer to these practice aids throughout our discussion. Please take a moment to download these practical tools before we get started. So let's begin by trying to understand the scope of the problem. Why is recognizing and treating VOD so important? Well, we need to understand that VOD has been reported in up to 20% of patients after hematopoietic cell transplantation. Now, mortality rates in individuals with VOD and either multi-organ dysfunction or multi-organ failure can be in excess of 80%. The most common cause of death for patients with VOD and multi-organ dysfunction is multi-organ failure. I really like this slide because it puts the mortality of VOD in its proper perspective. So this slide is going to look at mortality that's associated with several post-transplant complications across multiple studies. On the left is day 100 mortality, on the right is overall mortality. And here we can find many of the other complications post-transplant that we are familiar with. Note that acute graft versus host disease, either grade 3 or grade 4, associate with mortality rates that range from 40 to 70% by day 100. Here's engraftment syndrome and infection, mortality rates generally less than or around 10%. And idiopathic pneumonia syndrome with, yes, fairly daunting mortalities of 60 to 80% overall. But let's again highlight the excessive mortality that associates with veno-occlusive disease when it occurs with multi-organ dysfunction. And these data are from 19 studies that were included in a meta-analysis and really underscore how important it is to recognize and deal with this problem before it develops. We're going to move on to case-based discussions. We're going to have two patients and two pathways for the management of VOD after transplant. Alice is a 3-year-old girl with neuroblastoma who will be proceeding to transplant after aggressive chemotherapy and surgical resection of her tumor. Nathan, on the other hand, is a 24-year-old patient with CD33 positive AML who's preparing for transplant after intensive chemotherapy for induction and intensification. We're going to follow these patients and discuss how the transplant team can prepare, plan for, and intervene to address the development of VOD. So let's again start with case 1, Alice, our 3-year-old with neuroblastoma. She's going to actually be proceeding to her second in the tandem of 2 autologous transplants using myeloablative conditioning. The first question we must ask is Alice at risk for post-transplant VOD? Now let's consider that auto transplant is generally associated with a lower risk for VOD, at least as compared to an allogeneic transplant. However, tandem auto transplants certainly increase the risk. So we need to consider what are some things that the transplant team can do to assess and counsel families regarding risks of VOD. Megan, can you enlighten us on this? What would be your approach as you're seeing families in the pre-transplant period?
Yeah, so these patients and their families, they have an extensive consent conference with the physician team prior to their transplant admission, but also in meeting with these families, we're going to review their treatment history with them to assess their risk. And one of the main pieces of this discussion is that we're going to set some expectations in terms of post-transplant monitoring for VOD.
Terrific. Thanks, Megan. Thinking about risk factors, we're going to talk about risk factors that are modifiable, listed here, and later on non-modifiable as they relate to the development of veno-occlusive disease. So this table takes us through a number of modifiable transplant-related factors. They would include an allogeneic transplant, which is not applicable here, but a second transplant certainly is, the use of myeloablative conditioning regimens as well. There are several other factors that may be considered, but at least for Alice's case, we know that she has 2 modifiable risk factors for VOD. Now, we know she needs a second transplant, and we know that she would need a myeloablative conditioning regimen. So modifiable is in fact in quotes. It's not like we can do much about it, but in other situations, we certainly may consider that. Now, for a useful tool that summarizes modern risk factors for VOD, please download the practice aid we provided on this topic. Moving right along, it's important to know that neuroblastoma in and of itself is also associated with an increased risk for VOD. And in fact, there are several pediatric specific risk factors that one must consider. This can include very young age, for example, infants less than 2, a low body weight, and specific underlying disorders, including HLH, osteopetrosis, and several solid tumors that may require an autotransplant, including neuroblastoma. Getting back to Alice's case, she's going to move forward with her second tandem autotransplant using a myeloablative conditioning regimen. She tolerates her high-dose chemotherapy quite well. So as we're getting into the post-chemotherapy course, we need to ask ourselves, what is an appropriate post-transplant monitoring protocol? And how should team members plan accordingly for possible VOD development? Megan, can you take a minute and comment on the role of nurse practitioners and other nursing professionals in this context?
Sure, Ken. So we're going to be monitoring these patients extremely closely, and part of that is going to include tracking their labs closely. We're going to follow their renal and hepatic function, including coagulation factors, and additionally blood counts in terms of the labs that we'll follow. Additionally, we're going to do very strict monitoring of their ins and outs. We're going to be taking their weights at least daily or twice daily, measuring their abdominal girths at least daily or twice daily. And another very important piece of this is just going to be our physical exam, which is going to include assessing for right upper quadrant abdominal pain and distension, hepatomegaly, and any signs and symptoms of fluid retention.
Excellent. Well stated. Blair, can you comment on the role of the pharmacy team in this same scenario?
Sure. So in the post-transplant setting, a pharmacist is going to be most concerned with what's the patient's renal function and hepatic function. So similar to what Megan was saying, we will be monitoring labs to look for any impairment in renal or liver function. Something else a pharmacist can do will be to review the current medication list for any other medications the patient is on that could also be contributing to liver or renal impairment, as well as looking for medications that may need dose adjustments if we do have some type of liver or renal impairment.
Excellent. So right out of the gates, we understand that this is really a team approach to coming up with the best monitoring protocol to keep our eyes and ears open for any development of veno-occlusive disease. So as it turns out, Alice's second transplant goes along without much complications. She has an unremarkable course. She's fully engrafted for neutrophils and engrafting for platelets, and she's discharged early on day 21. We're following her carefully in the outpatient clinic, and after a long weekend due to a holiday, she comes in after 3 days and presents with some worrisome symptoms. These symptoms and signs include increased respiratory rate and work of breathing, abdominal distension, hepatomegaly, a 12% weight gain from baseline, and an elevated bilirubin up to 3.5. So it's important now in seeing this patient to consider how the team would interpret these findings. Megan, can you comment if you saw this patient, if you saw Alice in clinic, what you would be thinking about with these signs and symptoms?
Yeah, so these signs and symptoms are very suspicious for VOD, especially given the patient's risk factors. And although it is a little late, time post-transplant is not, VOD can occur at any time post-transplant. So this is definitely suspicious for veno-occlusive disease.
What other tools would you consider to confirm the diagnosis if in fact present?
So I would start with obtaining an abdominal ultrasound with Doppler to assess portal venous flow. In addition, I would grab some labs, which would help us to assess if for fractional excretion of sodium, which will show us if the patient's retaining sodium, which can also be an indicator of veno-occlusive disease.
Excellent. As Megan points out, this is a little late, quote unquote, for VOD, at least with respect to traditional criteria, but late VOD certainly can occur. And here is an example of a time course after transplant where patients are coming in and being admitted prior to transplant for their conditioning. They will get a central venous catheter placed, get their stem cells on day 0. And then, of course, they go through a post-transplant period of count recovery. And if everything is going well, potential hospital discharge with follow-up in the outpatient clinic. Now, traditionally or historically, signs and symptoms of VOD had usually been thought to occur within the first 30 days of transplant, but they certainly can occur later. And in fact, VOD can develop immediately after transplant or at later time points. When we're thinking about VOD, we're going to think about a number of clinical and biochemical signals. The signs and symptoms of VOD are listed here on the left: right upper quadrant pain, enlarged liver, weight gain, ascites, jaundice, sometimes shortness of breath that may be secondary to a distended abdomen due to organomegaly or ascites. And in that context, our patients can also be tachypnic. Laboratory values can include elevated transaminases, hyperbilirubinemia. You can actually see potential signs of decreased synthetic function of the liver, including a prolonged PT and INR. If organ function is associated with VOD, we could see signs of elevated creatinine or decreased GFR and decreased oxygen saturation in room air. You may take a moment to download some practical tools we have summarizing VOD symptoms, lab values, and onset, and use them as valuable resources for your practice. Now, this constellation, mostly of clinical signs and symptoms, have been included in diagnostic criteria to help make the diagnosis of VOD. These are the two traditional criteria for VOD: the McDonald criteria on the left, the Jones criteria here on the right. I'm going to start with the Jones criteria mainly because it is most strict, in large part because it requires that you have hyperbilirubinemia. Also take note, the signs and symptoms of liver dysfunction must occur within 21 days after transplant. You need to have hyperbilirubinemia plus at least 2 of the 3 following findings: ascites, hepatomegaly, or weight gain, at least 5% over baseline. The McDonald criteria soften this a little bit. You still have to have signs and symptoms of liver dysfunction within 20 days. You don't have to have hyperbilirubinemia, but it is included in the 3 possible factors that you would need to check at least 2 boxes: hyperbili, big liver or right upper quadrant pain, and weight gain, at this point only greater than 2% from baseline. These classic criteria have several limitations. First and foremost, you really can only make a diagnosis of VOD using these criteria if you're within 20 days post-transplant. As mentioned, the Baltimore or Jones criteria requires hyperbilirubinemia. That's addressed in part by the modified Seattle criteria. Moreover, neither of these 2 criteria really capture recent clinical descriptions of the disease. We're going to talk more about that later, nor do they include newer imaging capabilities that may be more sensitive and potentially more specific indicators of VOD. With these limitations in mind, we recently have developed some revised criteria to make the diagnosis of veno-occlusive disease, again, addressing these limitations. These criteria were recently published by Dr. Cairo and colleagues in the British Journal of Hematology in 2020. The new criteria allow for any two of the following to be true. Elevated bili, so you can have elevated bili greater than 2. You don't have to, but if it's there, you can check that box. Unexpected weight gain greater than 5%, big liver, right upper quadrant pain, and ascites. In addition, we now include excessive platelet transfusions. This is consistent with refractory thrombocytopenia. In other words, a patient may have a platelet count of 10. We give them a platelet transfusion. Their post-platelet count is 11. They're not responding to transfused platelets. This is a finding that has now become quite familiar in pediatric patients with VOD, but also some adult patients. And then finally, we allow for the finding of reversal of flow, of portal venous flow by Doppler ultrasound. So you can have two of any of these seven criteria, or any one of the following two. Liver biopsy tissue consistent with the diagnosis of VOD, or unexplained portal venous wedge pressure. Now, no one is suggesting that you need to get a liver biopsy or need to assess portal venous wedge pressure, but if you do, and these data in hand, it was believed important to include that information in confirming a diagnosis of VOD. So after our team-based assessment, let's consider the new diagnostic criteria analysis case. So remember, she presented with worrisome symptoms that were consistent with veno-occlusive disease. And it was late. It was about day 35 after transplant. Now, ultrasound goes on to confirm ascites that was suspected on exam and shows reversal of flow in the portal veins. So let's look at our revised criteria, knowing that we need two of any of the following, right? So she has elevated bilirubin. She has this unexpected weight gain from baseline. She has an enlarged liver. She has ascites that is confirmed by physical exam and now imaging, and the imaging also demonstrates reversal of portal venous flow by Doppler. So all considered, we can confirm the diagnosis of VOD in this case. Let's go to case 2. Nathan is a 24-year-old patient with high-risk CD33 AML. He too is preparing for transplant after getting induction chemotherapy, including gemtuzumab or GO. He's going to move forward with a matched unrelated donor transplant using traditional busulfan and Cytoxan conditioning, a T-cell replete bone marrow graft, meaning the T-cells will be left in, and GVHD prophylaxis that will include sirolimus and tacrolimus. Is this patient at risk for VOD? Megan, can you comment on that?
Yeah, so Nathan is definitely at a significant risk for veno-occlusive disease. Given his prior intensive chemotherapy, he's also getting an allogeneic transplant as opposed to an auto transplant. His conditioning regimen contains busulfan, which is going to put him at an increased risk. His graft source is going to be T-cell replete. And lastly, he's going to get GVHD prophylaxis with sirolimus. So all of those are going to put him at an increased risk.
Absolutely, well summarized. Now, this patient is a younger adult. So are there any differences in setting expectations for him versus the pediatric patient we were discussing before?
I think the biggest thing here is that the patient is going to be included in the discussion along with the caregivers in terms of expectation setting and things that we're going to be doing post-transplant to monitor him for VOD.
Right. I mean, we really have to enforce the fact that we need to collect, all of his outs. Every time he goes to the bathroom, he's got to kind of save and collect that for us. And we also need to know all of the things he's eating and drinking. And these may sound trivial, but in fact, they're very important for us to monitor his I's and O's in a very strict way. Now, we talked before about modifiable, quote unquote, risk factors. Here's a table of unmodifiable risk factors. These are essentially things that have occurred already in the patient's treatment course or more related to their underlying disease that we just can't change. So this table demonstrates a list of things that have a 3 to 10 time increased risk that can include recipient age, hyperferritinemia, pre-existing liver disease, etc. More importantly, over on the right-hand side of this table, it gives us a list of things that have a 10-time increase in risk. And that includes the use of medications like gemtuzumab, as Nathan received, or inotuzumab. Now, these are called antibody drug conjugates. They are non-conventional chemotherapeutic agents that can be used either for AML or ALL. It's important to know that they associate with VOD in and of themselves, and certainly if these drugs are being used as a bridge to transplant. So we really need to plan ahead in patients exposed to antibody drug conjugate therapy before transplant. So let's check in with Nathan again, particularly how the team can prepare for what may be in his future. So here's his past treatment history, and again, the approach we're taking to transplant. Megan, comment again on some of the things that we can do as a team to prepare for the potential diagnosis of VOD in this case.
So in this case, both as a bedside nurse and as part of the provider team, we're just going to really monitor these patients extremely closely. And that's going to include more frequent weights, more frequent abdominal girths, such as measuring them twice daily as opposed to daily. Additionally, we're going to really emphasize how important it is to monitor their ins and outs closely. And we're going to try as best as we can to maintain euvolemia in these patients.
Terrific. Blair, can you comment on the role of the pharmacy team, particularly in a patient who's received busulfan?
Sure. So something unique to patients that are receiving busulfan is that a pharmacist can do busulfan kinetics to make sure that the levels of busulfan are not super therapeutic, where they could be causing an increased risk for liver toxicity. And similar to the previous patient, since this patient is going to be at higher risk of VOD, we're going to be even more vigilant about any hepatic or renal dysfunction this patient may have, as well as definitely pre-reviewing medications that could be contributing to liver or renal dysfunction.
Terrific. So we can really underscore, the role of the team approach here, from bedside nurses to advanced practice providers to our colleagues in the pharmacy, to really kind of put together the patient's history, risk factors as we're moving forward, so that we can increase our vigilance for monitoring him or her for the development of veno-occlusive disease. He goes on to get his transplant. He begins his sirolimus and tacrolimus prophylaxis. And on day 11, as shown here, assessment demonstrates a number of worrisome symptoms. In fact, he too is developing weight gain, now 5% above baseline. He's developing refractory thrombocytopenia. He's got right upper quadrant pain. However, on his labs, his bilirubin is normal. So Megan, can you comment, what would be the next steps if you were evaluating this patient and you saw these clinical findings and this laboratory finding, even if the bilirubin is normal, what would be some of the things you'd be considering?
So one of the first things I would do is I would order lab studies that are going to give us his fractional excretion of sodium, and that's going to help us determine if he is retaining sodium. And secondly, I'm going to be ordering an abdominal ultrasound with Doppler and coordinating that imaging test with our radiology colleagues.
Excellent. I mean, yeah, it sounds like you're really worried that, some of these signs and symptoms can be consistent with VOD. So you're taking those next steps to help confirm that. But let's get the ultrasound. Now, assuming reversal of flow is confirmed, is that enough to further confirm a diagnosis of VOD despite the normal bilirubin?
Yeah, absolutely. So you do not need hyperbilirubinemia to confirm the diagnosis of VOD in this case.
Right on. Now, what if portal venous flow is normal? Does that rule out VOD?
No, in fact, he meets VOD criteria with his current symptoms of weight gain, the right upper quadrant pain, and his refractory thrombocytopenia already. So he does not also need the portal venous flow to be reversed to meet criteria for VOD.
Excellent. Well stated. In fact, let's go ahead and look at Nathan's case in the context of the modern criteria that could help confirm this diagnosis. So here's Nathan on the left-hand side. And again, he needs any two of the following criteria. He does have unexpected weight gain greater than 5%. He has excessive platelet transfusion needs consistent with refractory thrombocytopenia, and he's complaining of right upper quadrant pain. So you're right, on the bottom, reversal of flow, whether it's there or whether it's not there, we can still confidently make a diagnosis based upon weight gain, right upper quadrant pain, and the refractory thrombocytopenia of VOD. And that's really important, particularly in a patient that we knew was at high risk for this disorder. And that's despite having a normal bilirubin. Okay, so now we have these case-based discussions. Again, 2 patients, 2 pathways, underscoring the management of VOD. Alice, the 3-year-old with neuroblastoma, Nathan, the 24-year-old with AML. One, Alice, had late onset VOD. Nathan, on the other hand, had VOD confirmed despite his anicteric state. So let's see how the team can now address severity grading and maybe possible treatment. So we're catching up with these patients again. Alice on the left, Nathan on the right. We initially made a diagnosis of VOD, kind of early, a little later after transplant, but by day 36, she's now exhibiting pulmonary insufficiency and hypoxemia. So when we measure her oxygen saturation, her SpO2 increases from as low as 90% in room air up to 96% on nasal cannula oxygen. On the other side, in Nathan's case, by day 12, diagnosis has been made of VOD. The very next day, he's developing signs and symptoms of acute kidney injury. His creatinine is bumped to 2 times baseline. And we're noticing, because we're doing strict eyes and nose, that his urine output has fallen off despite the use of Lasix. So how should the team react to these worsening symptoms? We're going to get to this in a second. I want to first give you an idea of what might be going on here in the cascade of events during VOD that can result in organ dysfunction. So this is going to be a figure here that gives you an idea of disease progression over time. Lots of this is believed to begin with the buildup of toxic metabolites from conditioning regimens. That can actually include damage to the lining of the small blood vessels in the liver. They're called sinusoids. These are endothelial cells of the sinusoids. That causes narrowing of these small blood vessels and ultimately blockage of the sinusoid, hence the name sinusoidal obstruction syndrome. It is this progression within the liver that leads to the clinical signs of symptoms that we have been discussing and can be on a slippery slope to multi-organ dysfunction. Not all patients will progress to multi-organ dysfunction, but those who do have a very high likelihood of dying, as we mentioned before, traditionally in excess of 80%. It's important to know that the cascade of events in the liver begins before the clinical and biochemical manifestations of disease are present. Now, VOD with multi-organ dysfunction is very noteworthy. Up to 50% of patients with VOD can develop multi-organ dysfunction. That can be manifested as either renal dysfunction, and it can include something like decreased urinary output or increased creatinine. You don't need to be on dialysis. If you are, you can definitely check this box, but you don't need to be to check the box for renal dysfunction. Moreover, patients can develop pulmonary dysfunction, and that can include pulmonary infiltrates or simply a reduced oxygen saturation and the need for supplemental oxygen by a nasal cannula, or even increased respiratory rate. You don't need to be on a ventilator to click the box for pulmonary dysfunction. Important to know that patients with VOD and multi-organ dysfunction are on a very slippery slope to poor outcomes with an overall mortality of an excess of 80%. Now, grading VOD severity. This is something often forgotten. The reason being is that there were limitations to several of the older grading systems that we'll talk about briefly. Specifically, the older grading systems lack specific target organ grading toxicity, vague definitions, and I'll give you an example of this, of mild and moderate, and severe grading depended upon resolution or day 100 or death. So, you can either, if you were mild, it was really severity grading. If you were mild, you could have resolution before day 100. If you had severe VOD, you died. So there wasn't a lot of wiggle room in between. And all of this was retrospective in nature. And this is an example of the CTC-AE version 5 sinusoidal obstruction syndrome adverse event grading. So here's grade 2, grade 3, and grade 4. It really only talks about bilirubin to start with until you get into life-threatening consequences and death. So again, this is not very facile, right? It's kind of a little nebulous and really goes from, relatively mild, speaking only about bilirubin, all the way through life-threatening and death. as the only manifestations of grading. We wanted to come up with a revised multi-organ grading severity that could overcome some of these limitations. We know that our patients show hepatic and at times renal and pulmonary dysfunction. And if these findings were probably or directly attributed to VOD, we wanted to be able to include a bunch of factors when considering grading of VOD. That could include hepatic factors and renal and pulmonary factors. So let's look at this more carefully, noting that the overall grade of VOD would then be defined by the maximum organ grade toxicity. Grade 0 would be no VOD or SOS, grade 5 being death. So let's think more carefully about these revised grading classifications in the context of our two patients. Now, this is a little bit of a busy slide, but look here to the left, we're talking about hepatic factors like bilirubin, transaminases, portal hypertension, and fluid retention, and the grading that goes across the top. Now, in the case of Alice, we knew that she had hyperbilirubinemia. That was a grade 3, and reversal of portal venous flow. Her weight gain was greater than 10%, here grade 2, and she had symptomatic ascites. So we see she has grade 2 and 3 based upon her hepatic and fluid retention factors. Nathan, on the other hand, really here only has a grade 1 by these factors. Moving along, however, to renal, cardiac, CNS, and pulmonary factors, we can then again look at our patients and see where they grade out. Here's Alice. She has decreased oxygen saturation with exercise, intermittent supplemental oxygenation needs. So she has grade 2. Similarly, Nathan had an increase of his creatinine. That put him in a grade 2 as well. Remembering the overall grade is defined by maximal organ grade toxicity. So if we consider these things, there are several advantages to these new criteria. They're uniformly accepted organ-specific toxicity criteria, the organ-specific for VOD complications, including not just the liver, but also potentially the lungs and kidneys. They're contemporary. They're going to be prospective in time as the CTCAE grading is upgraded every so often, every 5 years or so. This is going to then allow comparisons across protocols and publications. It will automatically be amended with subsequent versions, as I just mentioned, and does not require new validations. So if we think about that in the context of our two patients, we can understand that both patients, Alice and Nathan, developed VOD, Alice late onset, Nathan despite anapteric status. They both went on to have multi-organ dysfunction, Alice with lung dysfunction. This graded out to be grade 3. Nathan also had VOD with renal dysfunction. However, his at this moment is only grade 2. So what are the next steps? Getting back to how our team approach can help understand the best management of these patients. So Megan, take us through the role of nurse professionals in approaching patients with veno-occlusive disease and multi-organ dysfunction.
Sure, Ken. So first, as the advanced practice provider, we're going to be working with our colleagues in the pharmacy to identify medications and fluids with sodium and to remove the sodium from those two things. In addition, we're going to implement fluid restriction. We're going to institute supportive care, for example, the use of diuretics such as Lasix. In addition, we're going to consider early implementation of Defibrite when it's indicated. For the pediatric patient, I would be talking to our colleagues in the ICU just to alert them of a possible transfer. And for our patient Nathan, our AYA patient, I would be consulting our nephrology colleagues to discuss management of his AKI.
Terrific. Blair, can you again take us through the role of your colleagues in the pharmacy to help with patients that are developing this complicated process?
Sure. So patients that have developed VOD, pharmacists can definitely do some interventions here. One being we can review the medication list for other hepatotoxic medications. Big one are azole antifungals. Most of our transplant patients will be on some type of antimicrobial prophylaxis and potentially fluconazole, voriconazole, so those type of antifungals. And being as we know that those can cause liver injury, maybe we want to switch to a different agent that doesn't cause hepatotoxicity. Another thing that we can do, for example, our AYA patient has some kidney dysfunction. We would definitely want to avoid any other nephrotoxic agents because we don't want to make that injury worse. And then we want to look at other medications to see whether they need dose adjustments based on the level of renal impairment. And then also, if the patient ends up on dialysis, we need to be mindful of what type or kind of dialysis they're receiving. Another thing that a pharmacist can do is review the intravenous medications for options or ways to reduce the fluid volume and also to restrict sodium intake. And we can do that by changing the dilution into dextrose instead of saline. We can also concentrate drips. So our AYA patient that may be in the PICU is probably going to be on a lot of infusions. And so if we can minimize the volume by concentrating drips, that would be very helpful. And lastly, you can also try to use enteral medications if possible. Enteral medications typically are lower volumes than IV medications, so that could definitely help in terms of volume reducing. And then lastly, a pharmacist can perform therapeutic drug monitoring for medications where we can monitor levels and we can adjust the doses accordingly to help reduce some of the renal and hepatic toxicity.
Excellent. Just very well stated, and really underscoring again, how we all need to work together for the betterment of these patients. Coordination with subspecialty teams is really critical. You can think of several critical care specialists, mainly to determine the best approach to manage pulmonary dysfunction in the setting of increased abdominal distension, as we saw in Alice's case, and overly just optimizing the care for these critically ill patients. We may need to reach out to our general surgery or interventional radiology colleagues. Is this patient that either the patients ultimately need a dialysis catheter placed? Do we need to tap and drain the abdominal ascites if that abdomen is getting so big that is compromising her lung volumes and leading to further respiratory distress? And in addition, as both of you guys had mentioned, really interacting with our nephrologist to help us manage acute kidney injury and decrease urinary output. What is the best way to do that? What is the dose and schedule of Lasix? Should we be considering a Lasix continuous infusion? Does that patient need to go on to receive continuous renal replacement therapy or some other form of dialysis? These are all things we need to be thinking about in patients who are developing multi-organ dysfunction. So what are the other current recommendations for treatments of patients with VOD in the post-transplant setting? Well, supportive care, we really touched upon this: diuretics, maybe paracentesis, hemofiltration, ventilation in the worst case scenario, fluid and salt restriction for sure. What about the use of Defibrite? This is an FDA-approved agent for the treatment of adult and pediatric patients with hepatic VOD with either renal or pulmonary dysfunction after transplant. So let's really keep that in mind, as Megan has brought up already. What about Defibrite? This agent is a sodium salt of complex single-stranded oligodeoxyribonucleotides. It's derived, believe it or not, from porcine intestine. And although the mechanism of action of Defibrite has not been fully elucidated, in vitro studies have suggested that this agent actually acts at multiple points across the VOD cascade that causes sinusoidal injury, narrowing, and sinusoidal blockage. And it turns out there have been several studies looking at the use of Defibrite in the context of patients with VOD with multi-organ dysfunction. And I'm going to just review two here for background. This was Defibrite versus historical control. So this was actually a phase 3 study that looked at 134 patients. VOD was diagnosed using the strict Baltimore criteria, and patients either had renal or pulmonary dysfunction by day 28. There were patients in the Defibrite arm that received Defibrite, a duration on average of 22 days. And of those patients, there was 102 evaluable patients. The historical control arm was actually selected by an independent medical review committee, and there were about 32 evaluable patients in that particular arm. So these were the data that came out of this study. The primary endpoint was day 100 survival. As you can see here, day 100 survival in the defibrotide group was superior at near 40% compared to the historical control of 25%, and that was significant at a p-value of 0.01. When you looked at a complete response by day 100, we also saw an improvement here. Of note, hemorrhagic adverse events of any grade were not different between the two groups. And this is the survival curve that demonstrates the improvement in day 100 survival in the patients receiving defibrotide. In addition, there was a much larger study, a TIND study for defibrotide, and this ultimately enrolled over 1,000 patients in over 100 US centers over the course of about 10 years or so. And these are patients who at least received one or more doses of defibrotide for post-transplant or post-non-transplant associated VOD. The dosing is described here, and the estimated day 100 survival for those 1,000 patients that received defibrotide for VOD and multi-organ dysfunction was as high as 60%. And here are the breakdowns here of the day 100 survival. The black is VOD with multi-organ dysfunction. The brown here is all patients, and the blue is patients with VOD without multi-organ dysfunction. So these data were actually pretty sturdy and also went into the FDA package that ultimately resulted in FDA indication. Here are actually the survival curves for both pediatric and adult patients, again, showing patients with VOD with multi-organ dysfunction in black, without in blue, and all of the patients here in brown. Again, seeing actually pretty sturdy outcomes in both pediatric and adult patients. It's also important to know that there have been several studies that showed that the initiation of defibrotide closer to the actual signs and symptoms of VOD and making that diagnosis is associated with a better outcome, including day 100 survival. So this graphic basically just shows, if here's your time of transplant, at some point you're confirming a diagnosis of VOD, the earlier you can initiate defibrotide, the closer you can get the start of that drug to the diagnosis of VOD with multi-organ dysfunction. That has led to improved outcomes. So there are some practical considerations for the use of defibrotide that really kind of span the entire management team. Blair, could you take us through the dosing and some of the other considerations for defibrotide use, please?
Sure. So the FDA-approved dosing for defibrotide is 6.25 milligram per kilogram every 6 hours as a 2-hour IV infusion. So this can actually cause some issues for patients that are on multiple IV medications, especially because it's given 4 times a day and over 2 hours. So a consideration that we need to think about is what is the available line access of the patient and IV compatibility of the other medications that the patient may be getting. In terms of contraindications and other considerations, defibrotide is definitely contraindicated with systemic anticoagulant or fibrinolytic therapy. Also, if the patient develops a severe hypersensitivity from the defibrotide, we definitely want to discontinue that. If a patient develops bleeding, especially with the first episode, we would typically hold the defibrotide, treat the bleed, and then consider restarting at the same dose once the bleeding is controlled and the patient is hemodynamically stable. If the patient has recurrent bleeding, then we would want to discontinue the defibrotide because they failed restarting it. If the patient has any invasive procedures planned, we would want to discontinue the defibrotide for at least 2 hours prior to the procedure, and then we can resume the defibrotide once the bleeding risk has resolved post-procedure.
Excellent point, Blair. Particularly because, as we said, these patients can be sick. They may need a paracentesis. They may need the placement of a pheresis catheter, and there's no reversal agent for defibrotide. But the good news is that the half-life is quite short. So the recommendations, as you point out, is hold the drug for at least 2 hours, do your surgical intervention, ensure surgical hemostasis, and then resume post-transplant or post-procedure if there's no bleeding. Megan, I wanted to ask you, something that comes up a lot is, can you initiate defibrotide in the setting of refractory thrombocytopenia? Like, aren't you concerned with bleeding in that context?
Yeah, so absolutely. And this does come up a lot, but you can certainly still initiate defibrotide in the setting of refractory thrombocytopenia. Given that this is a symptom of VOD, you're still going to want to fix the underlying issue, and therefore, hopefully that refractory thrombocytopenia would also improve or resolve.
Well stated and right on the mark. Absolutely agree. So we're finishing up here with some management recommendations. We're thinking about appropriate supportive care and defibrotide. For Alice, she had, really full bore supportive care, supplemental oxygen, diuretics, potential transfer to the ICU for management of her respiratory compromise, the need for paracentesis, et cetera. And she was in fact started on defibrotide at our standard dose, 6.25 mg per kg, IV every 6 hours. Nathan also had significant supportive care. We had nephrology get involved. He too started defibrotide at the standard dosing. Now, let's see how Alice has responded. So it turns out she had gradual improvement over the first several days and then went on to have resolution after 2 weeks. So Megan, how should we confirm response to defibrotide?
So in both of these cases, we're going to want to assess for the resolution of physical, biochemical, and the radiographic findings that led us to the initial diagnosis of VOD. So in the case of Alice, we're going to look for a decreased oxygen requirement, no oxygen requirement. We're going to repeat her ultrasound to make sure that the reversal of flow has resolved, and obviously an improvement in her exam and lab findings. For the case of Nathan, similarly, we're going to repeat the ultrasound. We're going to confirm that he's responded to treatment with defibrotide. There's no further, there's no reversal of flow, and that, again, the symptoms that led to the diagnosis of VOD have completely resolved.
Terrific. I think that's very, very well stated. And again, these are things that we can do to look at the whole spectrum of disease. Megan, do you think if someone has had a complete response by day 15, do we need a 21-day course of defibrotide?
So no, not necessarily. As I said, if everything that led to the diagnosis has reversed and has responded to the treatment with defibrotide, you do not necessarily need to continue.
Yeah, I would concur with that. The FDA indication includes a 21-day therapy course. However, if someone is really completely resolved, I don't think anyone is going to keep a patient in the hospital for continued defibrotide use if that patient is otherwise clear to go home. All the more reason to make sure we've looked at physical exam, biochemical parameters, and radiographic parameters before concluding that we've had a complete response. So this is now taking us to the end of our discussion. I want to, pause a little bit and get some take-home points. First, Megan, can you give us some take-home points from the nurse professional group?
Yeah, sure. So I think importantly is just knowing the risk factors for VOD and initiating very close monitoring and increasing monitoring if needed. Being very confident when you're making a diagnosis, and that's going to facilitate rapid interventions. That's going to facilitate the early discussion of defibrotide initiation and supportive care. And then that goes hand in hand with watching for organ dysfunction and rapidly progressive VOD, which again is going to lead to the initiation of defibrotide.
Excellent. And certainly that rapidly progressive VOD has been shown to be, kind of a risk factor for poor outcomes. So you're absolutely right. You want to be poised and ready to intervene as soon as possible. Blair, take us home with some take-home points from the pharmacy team.
Sure. So in terms of the pharmacy team, it's really about monitoring renal and hepatic dysfunction. That's kind of the bigger take-home point. So we can definitely help the team with medication dose adjustments and recommend alternative agents to help with the renal and hepatic function. We can also aid the team in reducing fluid volume and sodium intake, as I discussed about changing some of the IV medications around. And then lastly, we can perform therapeutic drug monitoring to also help reduce the renal and hepatic toxicity.
Excellent. Excellent. So as we conclude, I can't underscore enough how important it is to emphasize that it takes a team to manage patients with the multiple aspects, multiple problems of VOD in the post-transplant setting. And this is really going to include a number of things. Understanding pathophysiology. We didn't talk a lot about that today. We do know this is a cascade of inflammatory events, endothelial cell activation and injury and leak, ultimately resulting in sinusoidal obstruction. We need to, kind of capture VOD. We need to be able to facilitate early identification of risk factors, increase our vigilance of monitoring post-transplant so that we can be on alert for signs and symptoms of disease, make the diagnosis using contemporary and more versatile diagnostic criteria. Ultimately, it's best to be able to grade what is going on. We have innovative, now practical severity grading that is based on the NCI CTCAE version 5 criteria. And then finally, timely therapy really lines up with improved outcomes. We want to be able to augment supportive care with mechanism-based therapy. We want to try to early intervene with defibrite initiation. We know that early intervention improves survival. So we really need to kind of consider all of these things in a team-based approach, whether our patient is a 3-year-old, whether a patient is an adult, or in this case, an adolescent or young adult. These are all going to be extremely, extremely important at improving outcomes. So with that, I will conclude by thanking all of you for tuning in. This concludes our exploration of this team-based VOD management. Megan and Blair, really want to thank you for your input in joining me on this panel. I hope you've all found this activity informative and useful for your practice. Thank you again and stay well.
This activity is accredited by PVI, Peer Review Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/PGX860. This activity is supported by an educational grant from Jazz Pharmaceuticals Incorporated.